You all know we have no financial relationships to disclose. And I'm going to turn it over at this point, next slide, to Dr. Stenyan, who's going to be talking about advanced stewardship techniques today.
Yeah, so this is the last session we have scheduled, and we thought we'd kind of get into some of the advanced stewardship techniques. This was actually the first talk we gave the other cohort that are a little bit farther along in terms of stewardship. And so we thought we'd kind of give this to you all and see how it resonates. So this is just kind of the overview. We're going to talk, again, we like to review each time. We'll review a little bit of stewardship, core stewardship activities. We're really going to talk about prospective audit and feedback, and then formulated restrictions, and then get into some measurement in terms of appropriateness, which is really kind of a holy grail in terms of measuring stewardship activities. So you know this. This is something we've belabored over and over. It's the right patients, the right drug, right dose, right route, right duration. And I think the most important of all of those rights is the right patient. So if you don't get the right diagnosis, you will never get the right drug dose, route, duration, etc. So that right patient really is the most important. And the reason we do this is we want to make sure that patients receive the highest quality of care in the management and prevention of infections. And so we do that with this coordinated intervention with stewardship. So this is just general overview. Again, I point you to this document. This is a document that the CDC created with the help of us and a bunch of others across the US that really looks at developing stewardship programs in hospitals like yours. So in really small and critical access hospitals, stewardship's different. And it's really hard to take a national guideline and apply it to stewardship in a small critical access hospital. This document really gets into some of the specifics of what people are doing and gives some really good examples. And so it's a document that I would definitely pull out and read, especially for those that are new to stewardship and don't have a stewardship background. It really kind of goes over the CDC core elements of stewardship. The core elements, there's 7 core elements, and these are really what are the foundations of stewardship programs, and being really familiar with them to be able to speak towards them is really important. And this document and the previous one I showed really does that. So why stewardship? Oh man, we know this, but some numbers to back it up. Antibiotic use is not benign. 20% of hospitalized patients will experience an adverse reaction due to an antibiotic, and that's data from 2 years ago. Antibiotic resistance is occurring in populations and individual patients. You see resistance, I see resistance. This is inevitable, it's coming. Stewardship is one method to slow the development of resistance. Even now with some commercial incentives to develop new antibiotics in terms of trademarks, patents, all these things, we still have very few antibiotics being developed. And of the ones that we are, none of them are really oral antibiotics for the outpatient. These are really broad spectrum antibiotics targeting gram-negative infections that are going to cost a lot of money. And so we really don't have much in the pipeline. And, when you talk about stewardship to your leadership and to your clinicians, this last bullet point is the one you need to emphasize, is that, the reason we do this for antibiotics and not for any other drug is that antibiotics are unique in that the use in one patient can compromise the efficacy in another patient. And this is why we do stewardship. It's really because we're doing public health. And the usage of antibiotics here at Intermountain Medical Center can affect your community directly by development of resistance and spread of resistance. That's why when we think about this, and why Emily and I are such a strong proponent of really developing stewardship programs across the Mountain West, is because this is public health, and this is something we all need to be on the same page of. And so that's just kind of the background. But just to kind of emphasize some talking points there as you go on and talk to your leadership. All of that, in addition, stewardship improves cure rates, reduces C. diff, improves patient safety, reduces resistance, saves money. So there's really not a reason not to do stewardship besides the fact that, not organized and under a kind of an organization do it. So this clearly is the right thing to do. All right, so let's get into kind of some of the advanced stewardship techniques. So this is a slide that we've created, just how to do stewardship, or what is stewardship. Stewardship's a lot of things. Developing guidelines and clinical pathways, that's stewardship. Education, stewardship, dose optimization, IV to PO conversion, rapid diagnostics, decision support. All of these things are stewardship because you're trying to improve antibiotic prescribing. You may not call it as such, but it really is stewardship. The two pillars of stewardship when you read the guidelines are what's called formulary restriction or prior authorization. That's one pillar. And then prospective audit with intervention and feedback. That's another pillar. And we're going to talk about what these things are. In all honesty, these two pillars were created in big academic medical centers where there's ID pharmacists and ID consultation. And so do they go over to the small critical access hospital without ID pharmacists and physician? Yeah, they still do, but you may have to take a little bit of a different twist on them. So we really definitely want to kind of highlight what these things are. So the first one is formulary restriction. So this is eliminating certain drugs from the formulary. And so this actually has a huge impact in prescribing. If you don't make a drug available at your pharmacy, it's not going to be used. Okay, and so we've done this process with a number of our small hospitals that we've worked with, and the fact that they were putting on formulary 3 different carbapenems, for example, or they had on formulary really expensive drugs that don't necessarily need to be used. If you can eliminate them from formulary and eliminate them from being on the shelf in your pharmacy, you're going to reduce their use just by the nature of this. And so an example is dalbavancin and iridavancin. These are drugs that are given once weekly. They're highly kind of niche drugs. We don't use them at Intermountain Medical Center or any of our facilities. They cost between $3,000 and $4,500 per dose. If you don't stock them, you're not going to use them. And so that's one example of a formulary restriction. So what's the pro to this is it really you have a lot of control over which agents are used, and you can control cost. Providers are quick to catch on, and they understand, and they'll use alternatives, but it really is a nice mechanism to control costs and what agents potentially could be used. The con to this is you're not addressing appropriate or optimal use of antibiotics or use criteria, no education, and you need P&T, your Pharmacy and Therapeutics Committee support to really push this through. But it definitely is a method that we've seen work in small hospitals, that particularly those that have really been stocking expensive drugs that probably didn't need. So this takes a review of your formulary to really decide on, what are you going to try to limit. So here's an example. Hospital A Institute Stewardship Program, P&T has never excluded any antibacterial because of physician complaints. The new stewardship program comes in, reviews the formulary, and then gets rid of 4 of the cephalosporins that are redundant, and you certainly don't need it. So you're optimizing your coverage, and you're optimizing antibiotic prescribing in terms of fewer cephalosporins. So just an example of how you could use that to your advantage. So pre-prescription approval, this is kind of what people are historically calling restriction policies. So in this case, you need to receive an approval for the use of an antibiotic before the pharmacy will dispense. So if you want to use daptomycin, you need to call somebody and get approval. Okay. So the antibiotic is on formulary, but in order to get it, you have to get approval from somebody. Typically in the literature, this is through an infectious disease pharmacist or physician, but it doesn't have to be, in order to get to use that antibiotic. So the pro is that you get to guide appropriate empiric choices because they call you for the antibiotic. You say, no, the most appropriate drug is X, Y, or Z. You can also control big ticket agents, which can really reduce cost, and you can assist with appropriate dosing, duration, interactions, etc. This has been shown to be very effective. The con to this is it's time consuming and you need some level of expertise. You need to know baseline resistance. You need to know the pharmacology of the antibiotics and the spectrum needed. You need to be available real time, and it only impacts restricted agents. Okay, so if you only restrict 3 drugs, you're only going to get called on those 3 drugs. It definitely impacts upfront use. Initially, clinicians aren't going to like it because you're controlling what they can and can't use. But eventually, this becomes part of clinical care, and it's just part of your daily operations. The issue is you have to plan for nights and weekends. Granted, in critical access hospitals, your volume isn't as high on nights and weekends as it is during the week, but certainly you have to make plans for that. So within Intermountain Healthcare, we did a big study that looked at stewardship in small hospitals, and one of the components in that was restrictions. So in that top panel there, that's program 1. They didn't have any restrictions at all. They could use whatever they want. In program 2, had 5 hospitals as well. This program 2, these facilities restricted drugs at the local level. So we developed criteria for use. We gave those criteria to use to the frontline pharmacists in those hospitals. And we say, all right, you control the restrictions. And in program 3, again, we developed the criteria for use, but the ID physician or ID pharmacist controlled the restriction approval process. Okay, so if you look at the last line of each one of those boxes, that's a summary for the 5 hospitals above it. And if it's to the left of that dotted line or the referent line, that's 1, that means they reduced antibiotic use. And if you see the confidence intervals there are rather large just because they were pretty small hospitals. What we found is that when we restricted antibiotic use and it was controlled by the ID physicians and pharmacists down here, this bottom one, we reduced restricted drugs by about 85%. So they just essentially stopped using it. Up here in the one that was locally controlled, we reduced it by almost by 50%. Okay, so it was small numbers. That's why the confidence intervals are wide, but look at these hospitals here. You had a number of hospitals that reduced it just with local control of restrictions by almost 70 to 80%. So this is very, very doable. When you don't have restrictions, you don't impact the use of restricted drugs. These hospitals, the ones that reduce these restricted drugs, these were just 4 drugs: Dapto, linezolid, meropenem, and imipenem. That's about it. That's what drove all that. So it's definitely feasible. It definitely can impact change. You just have to think about how you're going to implement it. All right, so then prospective audit and feedback. So the definition is this: is a review of therapy at 24 to 72 hours after, oh, sorry, I'm getting a call here. After clinical and micro data are available. Okay, so what you do with this is that you allow the clinician to make the upfront decision, and then 24 to 48 hours, you're reviewing the case and bringing to the physician recommendations about optimizing your antibiotics. Okay, so how is this different than the 48-hour timeout? All the 48-hour timeout is a nudge to the clinician to say, hey, think about your antibiotic, make a decision about whether you need to de-escalate or discontinue. All that is 48 hours, just a nudge, it's a poke, it's a, hey, let's review this. Prospective audit and feedback is actually you as the pharmacist or the clinician, whoever it is, reviewing the drug, reviewing the patient, and going to the prescriber and saying, I think you should de-escalate from Zosyn to ceftriaxone because it's in accordance with our care process model or our algorithm. Okay, so you're going to them with a recommendation. Okay. So what's the pro to this is you've generated data to kind of sell your recs. You've seen how the patient has done over the past 24 to 48 hours. The diagnosis is much more established, and you can be more flexible in terms of when you approach them. You can educate the provider in terms of your algorithms, and it's more collaborative. The con is that it requires some expertise. You have to be really familiar with some of those clinical syndromes to be able to say, hey, the most appropriate care for this patient is ceftriaxone, not Zosyn. Okay, the recommended action that you're giving them is optional. You can't force them to really make a change. And it can be time consuming in larger centers. So here at Intermountain Medical Center, we have 500 beds. Half of those beds are receiving antibiotics at any one time. That's a lot of time to review. That's a lot of patients. So it can be really time consuming. In critical access hospitals or smaller hospitals, when you're thinking about censuses anywhere between 3 people to 25 to 50, the time commitment isn't as great, but you still have to have that level of expertise and comfort.
Dr. Stanyon, we have a question.
Fire away.
From Lori Wood. She would like to know if Dr. Stanyon and Dr. Spivak would be able to meet beyond this meeting series to review antibiotics in our hospital's formulary. If I put a list together of current antimicrobial agents we carry.
Yeah, I would think that would be something we should all do. And that's certainly something we could address as a topic of a forthcoming clinic where everybody goes and gets their antibiotic formulary, and we can all take a look at it and talk about it and see what other hospitals are doing, what other critical access hospitals are doing. We can come with our formularies that we have for our critical access hospital and smaller facilities and really kind of show what are ways we can really impact and clean those things up. Certainly.
That would be great. Thank you.
Yep. And I'd love to hear, once we finish this, whether or not you all think formulary management is something that could be improved upon in your facilities. I suspect it could, but I'd love to hear what everybody else thinks. So in terms of prospective audit and feedback, your targets, what are you doing with this? There's lots of opportunity with it. The biggest one is what we call streamline. So it's modification of the initial antibiotic regimen once more data is available. Okay, so it's the patient comes in with bilateral infiltrates with a white count of 13, and the prescriber gives them azithromycin and ceftriaxone, but in the next 24 hours, soon to realize that this is actually heart failure. Okay, so it's at that point where you can streamline to say, okay, do we really need this? And that gets into the next one, is discontinuation, where we can actually stop it. Okay, when you have a microbiology lab that is on site, many times in 24 to 48 hours, you're going to have more information available. So somebody comes in with urinary tract infections and sepsis, at 24 hours, you're going to have most likely a positive urine culture. Now, granted, that isn't always the case in smaller hospitals because you're sending those off to other labs. But at that point, you can say, yes, this clinical picture certainly looks like sepsis from a urinary source. This is our algorithm. We're going to switch Zos into ceftriaxone because based on our data, that's most effective care. Other things you can do is really look at dose optimization, making sure that the dose of antibiotic given really meets the indication. So if somebody comes in with meningitis, is on ceftriaxone, you're making sure that that dose is 2 grams Q12 instead of 1 gram Q24, etc. You can look at IV to oral conversion. People come in with pneumonia, have they met clinical stability? Can you switch them to an oral agent? Organism and antibiotic mismatch. Again, that's hard to do at 24 to 48 hours in smaller facilities given the lag in microbiology. But if you have on-site micro, that's something you can do. Drug-drug interactions, therapeutic drug monitoring, all of these things you can look at 24 to 48 hours. In the literature, this prospective audit and feedback can occur anywhere from 48 to 72 hours. But I'd say in small hospitals, the length of stay is generally shorter. I would move that up to 24 to 48 hours to make sure you're really getting effective and you're actually hitting the patients that are still in your hospital. So what's better, pre-authorization, i.e. restrictions, or post-prescription review of prospective audit and feedback? This has been a timely question in the stewardship literature for a long time. They're both effective, but which is better? This was a study done, you see the reference down there, that compares these two methods. This was done in a very large academic hospital out east. This was done at Hopkins. So whether or not we can take this information and make it generalizable to small hospitals, unclear. But just to give you an idea, they took one hospital which had a number of firms or floors, and they randomized 2 floors to prospective audit and feedback, 2 floors to restrictions. Then they did a washout period, and they switched, and they switched different groups. So what did they find? They found that post-prescription review that occurs at 24 to 48 hours, led to shorter total duration of therapy or days of therapy. Post-prescription review also led to shorter length of therapy, meaning that at that time that they reviewed the patient at 24 to 48 hours, they could also instruct the team to say, hey, that pneumonia only needs 5 days. And so the length of therapy was shorter, in addition to the total days of therapy, which is the total number of antibiotics. Okay. So little win in the column of prospective audit and feedback. So when you look at pre-authorization or restriction, though, that the antibiotic regimen was appropriate on day 1 was favored in the restriction category. So they come in, they call, I want this drug. You say, no, you can't have it. This is the most appropriate regimen, and they put them on that. And so antibiotic regimen appropriateness was higher on day 1 in the restriction group. You see no difference in C. diff, length of stay, or in hospital mortality. What I take away from this is that they're both good. They both offer some benefits one way or the other. And in actuality, you really want some of both. You really want a component of prospective audit and feedback in terms of review, and you want to control some high-ticket antibiotics with restrictions. That's the kind of ideal situation for these big pillars. And I would think about how we could do that in your facilities as well. Okay, finishing up, we're going to talk briefly about rapid diagnostics. This has been brought up a couple times. Rapid diagnostics encompasses a lot of things, and it really tries to get the microbiologic result further up in the course of care. And so that is done by any number of different things, but we have lots of technologies out there. The reason we do this is that, especially in areas that don't have access to real microbiology labs, is that what will happen is people get put on broad spectrum antibiotics. They think they want to continue that to the micro lab. The results are back, which may be 3 or 4 days. And if we could move up that result quicker, then we would be able to narrow our antibiotics and narrow our focus a bit more. So I've listed there a couple in terms of rapid diagnostic testing. There's something called PNA FISH, there's PCR technology, there's nanoparticle in terms of Verigene, there's MALDI-TOF, there's a whole bunch of different tests for blood, for urine, CSF, whatever it might be. Just know that if your hospital is thinking about initiating one of these tests, is that in order for these tests to have an impact in terms of antibiotic prescribing, you need stewardship teams to be engaged. You need the team to be able to take the result of the test, interpret it, and push the physician or the provider to change their regimen based on their test. When we've seen these tests be just kind of pushed out into normal care, we don't see any change in antibiotic prescribing. You really need that stewardship team to push that, to motivate the providers to change their prescribing. So whether this is a respiratory viral panel that you stick in the nose to see if you have flu, or if it's a stool test for C. diff or other bacterial pathogens, you really need to engage the stewardship team to interpret that test and make action. All right, so the last thing we're going to talk about is one topic within measurement. This is a topic we talked about before, and we've talked about what to measure, and the answer is it depends. And it really depends on who is asking. Is this your administrator asking you to measure? And then if that's the question, what is the intent of the measurement and what are the goals of the stewardship program? All right, is the intent to look for needs of improvement? Are you looking at cost or C. diff or resistance or outcomes? Well, it really kind of depends on what your goals are, will really dictate your actions and also dictate what you actually measure. Maybe you say, we just want to ensure we pass Joint Commission or CMS or what any of those kind of regulatory agencies. Well, then you have to determine how you measure the requirements for that. It also depends on the resources available. Do you have IT solutions? Do you have software? What's your hospital size? What's your staffing? Is this a manual evaluation? And so it really depends on what resources you have available will depend on what you measure. Is it desire for benchmarking? You know, if that's the case, you have to submit to the CDC under the NHSN AU option. And also, what's your reporting structure? Who are you reporting to? Is this reporting to P&T, medical exec? What are they looking for? So those are all things to ask yourself in terms of what to measure. The question I get a lot is, how do you measure appropriateness? Okay, and there's a great article, actually Emily was the lead author on this, is really getting into measuring appropriate antibiotic use. And there's a saying that says that all ID docs agree that 50% of antibiotic use can be improved upon, but we just can't agree on which 50%. And so how do you actually measure appropriateness? This is kind of my take on it, okay? And this is the way I'd like you to think about it. Our role as stewardship personnel and teams is to ensure patients receive the highest quality of care in the management and prevention of infections using coordinated intervention designed to improve antibiotic use and patient outcomes. Okay, so you've got a patient that shows up in your hospital, and then there's all these processes that go into treating that patient. So first you have to make a diagnosis. Then you have to give the best empiric therapy based on your diagnosis. Then you have to manage that infection. You have to get an echocardiogram with Staph aureus bacteremia. You have to remove catheters and line infections, all those infection management pieces. Then ideally you can de-escalate your antibiotics. You eventually hopefully can switch from IV to oral if possible. Then you have to decide on what's your length of therapy. If you do all of those things right, then you get better patient outcomes. So cure, decreased death rates, 30-day readmission rates go down, decreased resistance. All of these things improve if you do all of the processes correctly. So all of these processes, these are the things that make up appropriateness. And so when we talk about appropriateness, it's these things that we're measuring. Was the diagnosis correct? Was the empiric therapy correct? Did you do all the right things you needed to treat that infection? Did you de-escalate? Did you switch to orals? Those are the components of appropriateness. And so all of those things can be defined by you in your stewardship program under what we call a care process model or a clinical algorithm. Okay, so in terms of moving forward with appropriateness, first thing you have to do is you have to set the standard. Okay, you have to define what appropriate is in your facility. Okay, you can never tell somebody that they're doing it wrong unless you told them how to do it correctly. And so once you've set the standard, then you can assess the appropriateness against that standard, and you can be objective. Because then you can go back and you say, I'm going to review 5 cases of pneumonia in the past 2 months and see if they were treated in accordance with our care process model or our algorithm. And if they weren't, what components of that were non-compliant? You can do this with intermittent point prevalence surveys to evaluate the appropriateness. And these reviews don't have to be exhaustive. You can do 5 to 10 cases, and you can feed back those results to providers to say, hey, listen, your empiric therapy was correct, but you didn't de-escalate. Or, hey, your length of therapy was 10 days when it should have been 5 days. And you can show them your documents that you have. And ideally, they're the ones that have created the documents with you. And so they say, yeah, we're engaged with this and we can move forward with it. And so this, when you talk about measurement and stewardship, this is measurement for action. If you're measuring appropriateness and you can show providers this is where you can improve, that's where you have this collaborative relationship with your team. I'm going to end there.